Hi, everyone. Good afternoon. Thank you for taking out your valuable time and attending this webinar with us today. I'm Charu Madhwani, a physician and a public health professional, now working as a clinical engagement specialist at RX Health. I'm going to be the host of this webinar today. Today, we have with us two very special guests from Yale New Haven Health who are going to be talking about how the organization was able to ramp up 5,000 plus video visits in a single day within Epic EHR software. Our first speaker today is Nikki DeLucia. Nikki has over 20 years of combined clinical and administrative experience in healthcare. Nikki started her career as a clinician in physical therapy. For the last 3 years, Nikki's primary focus has been on leading the integrated Yale New Haven Health Services, Yale Medicine telehealth team, where Nikki oversees the ambulatory division and she's a part of both the strategic development as well as operational development of all ambulatory telehealth projects. Nikki is an expert in telehealth regulations, billing, and operational implantation processes. Our second speaker today is Charles or Chaz Kota. Chaz is an ITS manager at Yale New Haven Health. He worked as a manager for the telemedicine team for a couple of years before moving on to manage the Yale New Haven Health's innovation team and other projects. I also wanted to introduce you to our moderator for today's session. Today's panel discussion is going to be moderated by Richard Strobridge. Richard, or Rick, is the CEO of RX Health, and he's a renowned name in the digital health space, having invented first Bluetooth-based glucometer in addition to many other innovations. Before we get started on our panel discussion, I would like to establish certain webinar-related house rules. If during the panel discussion you have any questions, please feel free to write your questions in the Q&A box or the chat box, and we will ensure that all your questions are answered either within or during the panel discussion or after when we have our Q&A session with the speakers. We will first start with Nikki taking us through the workflow of telehealth, right from when the scheduler schedules the visit with the patient till the time when a patient visit is made with the provider. Hope you enjoy this webinar.
Our doctors who also help to prepare the patient, make sure they're set up, and then again, they can troubleshoot, and then again, they're there. And hopefully once our provider joins, they can focus on their clinical experience and do not have to worry about any of the IT issues that sometimes can occur during a video visit, since this is so new to all of our patients.
And it sounds like a lot of that is automated, which is excellent. So you don't have to really, send out a bunch of reminders and that kind of thing. It's sort of batch processing. Do you have any comments on that, Chaz? And from an IT perspective and sort of ease of use and that kind of thing.
So I will say one of the best parts about this is as we've grown our video visits, it's been very easy to add other visit types, transition to other service lines. Like, for example, in the future, we're actually going to be starting to send text messages to remind patients to download data for remote patient monitoring. So it's very easy to get you guys, data to send out these text messages. It honestly is like a very little lift on our part to get it done. It's more of just providing you with the visit type, the department name, and then you guys can kind of just reach into Epic and pull it out. Previously, we were using reports, but we're going to start using the Epic App Orchard soon, I believe.
Right. Yeah, the Epic App Orchard allows the platforms to be implemented very quickly because all of the security protocols and HIPAA and all that has already been dealt with, and so getting an instance of this up and running is quite quick from that standpoint. And then my understanding is at the end of each of these care pathways, if you will, there is a survey. And so what we've got to show you next is a few slides that have the different survey responses. And when I first saw these, I was quite amazed. My family member, I was satisfied with the video visit expectation instructions from the provider or the provider's office. huge majority of the, approximately 14,000 people that took the survey strongly agree or agree. I think that's significant around, sort of the ease of use and the ease of being able to perform a video visit. And then the next one, Charu, was the patient and their caregivers, their family caregivers' interest in potentially using video visits in the future and for future appointments. Again, strongly agree. The vast majority of the responses, and so I think that says a lot about the ability for the platform to effectively scale even with sort of an automated outreach. I'm curious if the text messages that you're sending out, are they personalized to Yale New Haven Health or even the provider?
So when we were first using the survey results, yes, they would go out immediately on the night after the video visit. So it was easy for a patient to correlate that this video visit, this survey is in regards to the video visit that I just had today. So yes, of course, we work with you all the time to develop the messages that we want sent out so that the patients understand what it was from. I will say, just as we continue to go through these, we have transitioned away from using this for the surveys because one of the things that's happened nationally is that Press Ganey, which many entities use across the country, has actually finally put telemedicine questions into the Press Ganey survey, which is a standardized way for many of our entities to gather information and feedback from our patients. And so we were using this survey prior to that, and now we've transitioned to the Press Ganey survey. But our results are still very similar to what you're seeing here when we did this. I actually have to say that sending it out the night of, I think you get a lot better response. It's something that people may want to think about. When you send out and use Press Ganey, they don't necessarily get that survey immediately. And so to your point, Rick, they may not correlate it exactly to what happened in that moment, where I think you're seeing the great results here because it's fresh on a patient's mind and they were easily able to answer the questions and give proper feedback.
Right. Yeah, that makes a lot of sense. And thank you for that commentary. The next slide, Charu. How much time did you and or your family members save by having a video visit? This includes travel, wait time, and time off from work. The vast majority, again, less than an hour or 1 to 2 hours. And I have unfortunately been in appointments where it has been 2 to 4 hours. So I'll say that, this looks very appealing to me as a patient or as a person that's supporting a patient that needs to do, a primary care visit or any other kind of video telehealth visit. The time savings, and when you equate that to, efficiency and value and cost of time, this is quite valuable to the patients, and I would think that they would certainly recognize that and be approving of it. And then I think the last one that we had was there one more after this or not? No?
No, this was...
Okay. Yeah, so I think it gives you, thanks a lot for that, Charu. I think it gives you, a feel for both the provider perspective, the IT perspective, as well as the patient and the patient's personal care team view of how this system is working. Let's now dig into a little bit more detail in terms of the platform itself and how it's being used today. And I will say that if there's anyone in the audience that has interest and has any specific questions, feel free to use the chat window within the Zoom webinar to ask us any questions, and we'll get to some of those questions when we reach sort of the end of our system, the end of our webinar.
Rick, I wanted to chime in and say that we have 2 questions in the chat, and I think that it'll be relevant now to get them answered. So the first question is by Michelle. She asks, are you currently or plan to have disease activity assessments in the workflow prior to visits?
So that probably goes to a lot of our remote patient monitoring work that we are still working on. Again, that came to the forefront during COVID. We had a few pilots here and there prior to COVID when it comes to remote patient monitoring. So, I mean, the basic answer is yes. We are planning to move forward with all of that, and I'm sure we will work with RX Health when we need to. And we did work with certain things. Again, I know that Chaz can tell a little bit about what we did with GI and do some care pathway work there. Chaz, if you want to jump into that, just to explain to Michelle.
Yeah, so for GI, what we specifically did is we gave the APRNs and the physicians access and the MAs all access to send the patients. We basically prescribe them with instructions prior to their appointment. So right when they're seeing them that day, they prescribe it right then and there while the patient's in front of them. They verify that they get it on their phone. And then it also goes out prior to their appointment when they're coming in for their procedure. And again, that's just basically, you know, what to take, what you need to do when you arrive, where to go. And it allows the patient to not have to have that paper folder that they typically get before they come in for a procedure. They get
Right.
a text message with a link that goes to the PDF file. So they can never say, I can't remember where I left that. It's always right in their phone, and it's always in that text message, and we can resend it as many times as we want.
Mm-hmm. Yeah, absolutely. So it just shows how this automation can work for in-person visits as well as televisits. Great.
We have another question from April. She asks, what is the name of the application in Epic that allows it to send data to patients?
So we send data to, I think she's talking about the Epic App Orchard. So what that does is it basically allows us to query third-party applications like RX Health can reach into our Epic instance and pull out data for the patient so they know who to send it to. We're not actually sending it from Epic. It's actually RX Health that's sending that information to them.
For the care pathway, right? And then the patient-facing app is the Epic MyChart.
Correct.
Correct.
We have another question from Tim Tohi. I'm not sure if I pronounced the name correctly, but the question goes, how has the integration of RPM work been evolving with telehealth, and did your WRVUs or billing on the back end run into issues with the shift to telehealth volumes?
So we're still working on a lot of that. We have a whole separate subcommittee that's kind of filtering through all of that data and all those different vendors right now. We don't really have I can't give you too much information on that. It's more of still a work in progress. We have RPM that we're doing with a few pilots, but no real set plan forward at this point. Just that we're trying to filter through, like, you know, these are our goals for the year and just figuring out how we get there.
Yeah, RPM is definitely something out of all of our telehealth workflows is in its infancy, I would still call it, compared to where we are with everything else. And so again, probably like many of you are out there, just trying to figure out what vendors we want to couple with, what's the most important, which of our specialty clinics does it make the best fit for, and working through all of that. Because again, anytime you start talking about remote patient monitoring, it really comes down to an operational workflow and having all of that in place besides the IT side of it as well. So there's a lot of integrated work that you need to do.
Yeah, and I know that, you know, as a person that ran an RPM company for a number of years, I know with the CARES Act and CMS, it's a moving target with RPM these days. They've been very supportive, and the federal government in general has been very supportive of remote patient monitoring during the COVID, in addition to telehealth. And so I know that they're looking at discontinuing some of the remote patient monitoring codes, and then they're also looking at permanently keeping a number of the codes that have been developed. And in many cases, the states and the the state programs and Medicaid programs are following suit as they always do. Any other questions there, Charu? I think you can stop sharing now if you like. Then
I think there's one more. There's a comment from Parth. It says, even with all the reminders and help, what is the percentage of no-shows and technical difficulties on the part of the patients?
that's a good question.
So we've actually seen the no-show rate drop when it comes to video visits because, again, when you think about the patient experience, it's actually easier for them, right? They can connect and still be, I always say I prefer to do it, right? I'd prefer to be multitasking, waiting for my provider to connect with me than to be sitting in his waiting room waiting to get in. And so I think the no-show rate because of that has definitely dropped. Yes, I totally agree with the fact that technical difficulties could definitely lead to some errors, and it all depends on where you are. We recently just went through a platform upgrade. Prior to our upgrade, I would say we had minimal technical difficulties because everyone from March to present knew what they were doing. We just recently switched over our platforms, and that created some technical difficulties that we've had to navigate through and improve the processes very quickly and make a lot of pivots. So it all depends on where you are in your implementation process and what you're trying to roll out. But once you have everything set, again, technical difficulties should minimize. There are always going to be technical difficulties on the patient side, right? There are thousands of types of devices that any patient can connect with, and not everyone is tech savvy. So you're always going to have audio visual issues. But the best thing that you can do for that is to teach your providers and anyone else that's part of your workflow on how best to troubleshoot those things.
And one of the things that we've actually built in to our RX Health platform is if people are having technical difficulty issues, we did build in the ability to send them a direct link through RX Health to their meeting. So if they're having issues signing into MyChart, or if they want a family member to join, this new technology and coupled with RX Health allows us to do those things.
Yeah, I think it's very important to know that we chose to go down a route with an integrated platform within our EMR. This allowed us to already use the workflows that we had in place pre-COVID that met our state regulations and hit all the HIPAA compliant marks, even though we know that CMS opened up the ability to use things like FaceTime and many other applications. We knew long-term those weren't here to stay, so we continued to march forward on our integrated platform. And again, we realized though that we needed an easy process for those people who couldn't join via our patient portal, which is MyChart, a way for them to get into the visits more easily. And that's what we used RX Health for, to create that link that Chaz was just talking about for those patients that did have trouble connecting, which again brings down our no-show rate and the patient technical difficulties by having that as our second option for our providers.
Right, right. Yeah, that's a really good comment, and it sort of leads me to my thought process around, and I think probably some of the people that are on this call are thinking, if they haven't implemented telehealth already, you know, thinking back to when you first decided to do this and then the implementation, because I think that if I hadn't done it and if I wasn't involved, I'd be like, well, you know, where do I start, right? And then could you both sort of walk us through that process of getting it up and running and the details of that?
I think we were lucky in the fact that we had everything there pre-COVID. We knew what platform we wanted to use. It wasn't like we were starting from scratch. We just had to build upon it. So our biggest challenge was once COVID hit, and here in the Northeast, that was in the March, April timeframe, when we literally closed down our clinics. We had to then teach thousands of providers how to do telehealth, because prior to that, we were just in pilot mode and we were working with people here or there. It's not like everyone knew how to do telehealth. So our biggest challenges were around the providers. One, setting them up with the IT that they needed, making sure they had it. Then they were working from home at that point. They weren't even in their clinic, so adjusting to that. Then we had to train them. So getting a whole training platform out there, ensuring that they came to training, knew what they were doing. And so that was just the provider side of it. Then you had the whole patient experience. I mean, again, here in the Northeast, many of our patients never did telehealth before. And so again, saying to them, we're gonna have you seen over a video visit, it wasn't enough. You had to explain to them, what did that mean? How am I going to do it? So then we had to have scheduler training, having schedulers explain to our patients what this means, why we're converting you, that our clinics are closed. And again, so it was marching through all of that in such a short period of time. Overwhelming, but I guess I always continue to call this the silver lining of COVID, because it just pushed telehealth forward and it's here to stay.
And just to echo what Nikki was saying, I think one of the technology is there. There's many different platforms, many different ways you can go about implementing what we did. I think the more difficult part is making sure that you have the strong organizational leaders and the clinical champions, operational leaders. Like, so for example, we had Nikki from the operations side that really pushed forward and made sure everyone knew what to do, was able to get the right clinical champions involved, because the technology is there. We can implement Zoom or any of the various platforms that are out there, but making sure that you can operationalize it, that's the more difficult part.
Sure.
That's honestly where the most flip is, in my opinion.
Right. So from an IT standpoint, and you're the IT guy, right? It was relatively straightforward. But then, like Nikki said, getting the providers trained up who had never done this before, and all of a sudden they were sort of scattered to the wind, right? They were all working from home, and trying to get everybody trained and working on it is certainly a monumental task. Um, so. I'm curious because I've seen some of the reimbursement codes. They're starting to try and determine whether they're going to continue. Has an equilibrium been reached? I mean, I assume you're not doing 5,000 televisits a day because your facility. Well, maybe tell us, how open is your facility, and sort of how does the reopening relate to the number of telehealth visits?
Yeah, so 5,000 a day was definitely our max during COVID when all of our clinics were shut down across our system. We've we've reopened our clinics. That happened here in the Northeast around the June timeframe. And
Okay.
so since then, definitely people who need it and who are appropriate to have it are coming back for their face-to-face visits. And so we are seeing that right now, that leveling off of where does it make sense what percentage, right, does telehealth make sense to continue marching forward on, and what percentage that needs to be face-to-face moving forward. And again, we are PCPs, we are multi-specialty doctors, and I think that varies from specialty to specialty. But we here at Yale have set a goal of 30% that we will remain on telehealth for 30% of our visits moving forward. We're ebbing and flowing through that. We have not yet hit that 30% mark to maintain it. Again, some departments that it makes sense for, I can tell you off the top, easy things like dermatology or our psychology visits, things like that, they're maintaining 80% of their visits at telehealth. But other specialties like radiation oncology, where you need to come in and have a procedure
Right.
with your E&M, it doesn't make sense for them to be doing telehealth, and they're down lower in maybe the 5% range. So it does vary between departments and specialties, but our leadership, again, has put out that goal for everyone to know that we are going to maintain telehealth, and as a system, we hope to hit a 30% mark and maintain that moving forward. But to your point, Rick, moving about the reimbursement, it will all be determined by that as well. So, I mean, as you mentioned, again, as we all know, things are in Congress, it's at CMS, federal pay, they're all discussing where it's going to sit moving forward. We do honestly here at Yale feel that it's here to stay. We do think reimbursement will continue in some fashion, in some form moving forward for Medicare, for Medicaid, and even with our commercial payers. Again, another strong suggestion to those in the audience is to have your telehealth team work closely with your payer relations group so that you can have telehealth be part of your specific contracts rather than relying on payer policy, because those continue to keep changing. And if you get telehealth onto your contracts moving forward, then you don't have to worry about what those policies says. And that's what our strategy is moving forward.
Okay, great. Yeah, there seems to be, and it's around election time and sort of the changes in federal care policy. There seems to be a big push toward Medicare Advantage plans and increasing Medicare Advantage. Could you maybe talk a little bit about Medicare versus fee for service versus value-based care versus ACO, and sort of your thoughts around how those all work together? Or don't?
Yeah, I mean, I really think we're going to have to see where that all lands in the future. But I think that telehealth can fit into those dynamic discussions going on, right? I mean, if you're talking about value-based care, of course, telehealth can play a great role in that. People just need to understand where it fits in, right? And so I think it's so new that people don't understand that yet. But there's a lot of conversation that can happen to show the value of telehealth moving forward in any of those pathways that are chosen of what we go forward on.
Mm-hmm. Yeah, that's a good comment. I mean, I could go on with my questions for a long time. I know, Charu, I think that you had a survey that you wanted to do. Is now an appropriate time to do that?
Now is a very good time to launch our poll, where we wanted to ask our audiences if you are currently doing telehealth visits at your organization. Are you seeing an increase, decrease, or the number of visits staying about the same? It's a great time because we just spoke about it with Nikki, asking her about the Yale New Haven Health what's the status? And we also wanted to know from our audiences. The second question would be, what is the greatest challenge you face in adopting telehealth? Is it reimbursement clarity? Is it technology issues? Is it longer time to implement, or workflow issues? Uh, some very specific question we have for our providers is, what are the challenges you are facing with the telehealth solution at your organization? Is it increasing digital divide? Is it security breaches? Is it issues with reimbursement for service? Is it lack of educational support to patients? Or click not applicable if it is not applicable to you? The last question from our poll would be, where are you in your journey to adding asynchronous care and remote monitoring to virtual video visits? Are you in concept, in pilot, few implementations, fully implemented, and not interested? So I can see that a lot of people have voted already, but we would give some time for the poll results to come in, and I'll announce it soon.
Okay, great. And I've got another question that maybe we can handle while the poll people are voting. And one, it's from Shen. Thanks for your question, Shen. It says, does your care package have specific or enhanced steps for older adults for all steps related to video visits and specifically for e-check-in? Do you do anything different for that?
So Nikki and I have been working on this for quite a bit of time now. So one of the things that we recently just implemented is an outreach group that calls patients who are over the age of 65 prior their new visits to our health system. So we previously used to use the regular RX Health pathway to send them text messages, but we found that some groups needed additional support. So we just started literally within a couple weeks, and we're utilizing all of our tools. So Epic, actually there's the ability within RX Health, we haven't done it yet, to actually press 1 if someone needs assistance and have it put them in a list for us to call. But we are reaching that older population with, we're calling them our TAG group, our telehealth assistance group. And Nikki can kind of explain a little bit more there. But that's one thing that we've been pushing really hard, because we do know that experience is one of the best ways to get people to come back for telehealth. And so we want to make sure that we're providing them with the support they need, so that way they do have a good experience.
Mm-hmm.
Yeah, I will say that one of the things that came out of the COVID was that we very quickly set up what we call the telehealth conversion center when COVID first hit for us in March. And what that meant was, not only did, obviously when we closed our clinics, we had to then convert all of our face-to-face visits to telehealth visits. And behind that, what we did was we set up a volunteer team. So these were people who worked here at Yale who maybe had their jobs displaced because they just couldn't work because they all had hands-on work and campus was closed or whatever was going on. And so we had set up this team of volunteer callers to help call people regarding their video visits. And at that time, we called anyone who had gotten transitioned. And through all of that data that we collected from March to now, we realized, and I think it's simple as you're asking the question, is who was the demographics that stood out to us, and it was our older population. And I'm not saying they all, because there are some that are very tech savvy out there, but for the most part, it's our 65 and over. And that's why in this tag team that we just developed, we've actually set a prioritization in a tiered methodology. And so we call all of our new video visit patients ages 65 and over first. And that's who we prioritize. After that, we call our pediatric patients, because again, you're dealing with peds and the parents, and sometimes there's proxy issues on who you're allowed to talk to. And so it gets a little complicated. And then after that, our tier 3 is anyone else who's a new video visit patient. And so we do it in that order because we realized through all of this work we've done since March, who actually needs the most help out there.
I will say one more thing about our elderly patient population, and this is just a provider story. One of our providers was telling me about a 97-year-old patient that he does telehealth visits with frequently. And the patient absolutely loves the fact that we send them like the reminder text messages, and they can just, click the link to download MyChart when they get a new phone, because they hate driving into New Haven, Connecticut. And the fact that they don't have to worry about parking, they don't have to do any of that anymore. And the fact that they're 97 years old blows my mind, that they're able to do it so easily.
Yeah.
It just shows that you can be successful with our older population. They just might need a little more help.
Right. No, that was an excellent question and excellent answers. It really lent a lot of color to the discussion. So thank you for that. Charlo, do you want to go through the poll results now?
We are in the poll. And for the first question, where we asked if you're currently doing telehealth visits at your organization, are you seeing an increase, decrease, or the number of visits is staying about the same? So 50% of our viewers answered that it has increased. 43% said that it's decreasing, and 7% said that it's the same.
Yeah, I think that probably echoes the experience at Yale as well, where it increased rapidly. Maybe it's around the time frame that you're asking the question. So increasing and then decreasing, and has sort of reached an equilibrium.
Yeah, and I'll just add a comment to that. I don't know if other people are seeing this within their systems, but one of the other things that we're facing right now is, again, you went from doing 100% full-on telehealth to now you're trying to integrate it into your clinics, right? And so what we are finding and what our providers are loud and clear saying is it is not easy to do a smattering of telehealth here and there. To go from a face-to-face visit to a telehealth to a face-to-face doesn't work well, because you're never necessarily running on time in face-to-face. We all know that world, right, with our providers. But yet on a telehealth visit, they're there and ready for you at the moment that visit is supposed to start. And they may not hang on. They may hang up on you and not be there when you want to join 15 minutes late. And so what we are working on is dedicating telehealth sessions and having our providers pick one of their dedicated clinics a week just to telehealth, and pulling all the telehealth sessions out. And so as we do that, we're seeing our ebb and flow. And I think that's where we ultimately will hit our mark of what the percentage we want once we get all this operational work to get that in order. And so again, just a good thing to think about as you decide where does telehealth appropriately sit within your clinics.
Right. So instead of sliding telehealth visits in with in-person visits, you're dedicating a block of time just to telehealth.
Exactly.
Okay. Yeah. That's an interesting operational comment. Second one, Charlotte?
Yes, the second question is, what is the greatest challenge you face in adopting health? 71% of our viewers answered that it's workflow issues. 50% answered that it's technology issues, and 21 reimbursement and time to implement. So we can see that the maximum number of our viewers answered that the greatest challenge for them to adopt telehealth is workflow issues.
Any additional comments on that, Nikki or Chaz? It sounded like from your standpoint, the technology was pretty straightforward in implementation, but the workflow and fitting it into your current existing workflow. And it sounds like you've actually just, from your last comment, you've actually changed your workflow to set aside a block of telehealth time.
So the technology is relatively straightforward. I will say that it does have its barriers when it comes to teaching providers and patients, like Nikki said before. It works when the user on the other side knows how to use it. It's that education, and it's that that teaching that you really need to have in place in order for it to be successful. I've done video visits, I can't tell you, probably thousands of times at this point, and I'm always successful, but I'm a technical user. I know what I'm doing. It's really important to make sure that the providers have that in place. Otherwise, they won't be successful, and your program won't do well.
Yeah, that's another good point. Setting up a robust training around your telehealth, whether it be for providers, schedulers, front desk, check-in, check-out, because again, everyone has some, it's a different role, right? It's now virtual, the way they do it, but still things have to happen in the workflow. So making sure you're hitting all of those areas are very important considerations in a change in workflow that isn't always easy to implement.
Yeah, it very much takes a village, right? So it's not just about the technology savvy of the patient population. It's all about the providers and everyone else that has to support a successful telehealth visit, right?
Right. But I think that's important to think about. And again, Chaz has mentioned this before. This is where we feel like where RX Health can help us and where it can fit in. Right now, we have this new, send a link if someone's having trouble, that it's at the point where the provider can send it. But we're thinking about, why can't we send that earlier? Can we use that send a link for other things, like being able to send them the download directly of the apps that we need, or other things, and have that maybe sit with a scheduler sending it and saying right then and there, did you get it? Let's walk through it now. And again, trying to automate as much as we can for the success of that video visit.
Right, right. And, you know, and what we've found is every institution is obviously unique and every institution has their own workflow. And so the ability to not only be able to customize the messaging out to the patients, you know, when you get a text message from your doctor, you're going to look at that text message, right? So being able to customize it from that standpoint, but also being able to customize it from a step-by-step pathway standpoint to make it, or at least help it to fit into your existing workflow. Cool. Number 3.
Yeah, so the number 3 was especially for our providers, and 43% said that it's not applicable to them. And majority of the providers said that lack of educational support to patients is one of the challenges that they face while using a telehealth solution at their organization.
Interesting. Lack of educational support.
On the patient side, I mean, that, yes, getting that patient prepared, because again, that is not, we understand that's not what our providers want to spend their time doing. They do not want to be dealing with audio and visual issues.
Right.
They want to get right to the meat. They want to do their clinical work, and that's what they're there to do. So we try our hardest to get to our patients so that they can have that, and that's what our providers can focus on.
Excellent, excellent. Thanks.
The last question we asked was, where are you in your journey to adding asynchronous care and remote monitoring to virtual video visits? So majority of them said that they are still in concept, and 29% said they have made few implementations, and 14% said that they have fully implemented the remote monitoring.
Yeah, I think the most interesting thing here is the not interested one with 0 votes. So it sounds like everyone's at least thinking about it and knows that it's coming. It's just the phase in which they have, or the phase or the stage in which they are in implementation. Nikki, Jazz, do you have any comments on that? I know that you're really, it's mostly telehealth, right? You're not doing remote patient monitoring.
So I'm actually in the remote patient monitoring work group. And again,
oh, great.
Like we said before, there's a lot going on right now. It's still in its infancy. We're working through different vendors. We actually do, there's different forms of remote patient monitoring. Honestly, there's, you know, anti-coag, there's diabetes, there's implantable devices. It really depends on the flavor. But again, that ultimately comes down to operationally, the technology is there with the various vendors. You just need to be able to have the operational staff in place to monitor these patients. And then a lot of that also depends on what you're charging for that remote patient monitoring, because if it's supposed to be 24/7 monitoring, you need to have staff in place 24/7 if that's what you're billing for. If it's just, you know, you're checking in monthly, that's a whole different type of remote patient monitoring.
Mm-hmm.
So it really depends on what you're trying to do, what technology you're using, and, you know, how you're interacting with your patient.
Mm-hmm. Yeah, that's really good comments, because it doesn't, remote patient monitoring isn't vanilla. It comes in a lot of different flavors, right? Yeah, for sure. And I think that, but I think a lot of the concepts that we've discussed during this discussion also apply. You know, it's all about ease of use, being able to easily deploy, being able to get the data, and then, okay, I'm getting this data, now how do I fit it within my current workflow, right?
And I will tell you that some specialties have been doing remote patient monitoring for quite some time now. Cardiology, endocrinology, they've been monitoring their patients remotely for quite some time without, honestly, a lot of help from IT. But now that I think that there's eyes on it, I think there's a lot of improvements that can be had in those areas.
Mm-hmm. And we've got another question from our audience. Eric, thank you for your question. It's, do you use tablets or gateways and hubs for your remote patient monitoring? In other words, do you have a tablet which gives the patient additional information, or is it just a data collection device?
So we actually have, I'm going to take a step back from that question, and basically what our remote patient monitoring work group is looking at is developing a formulary on what are actually the needs out there that providers want. And again, I think it's from starting with the basics, right? Can the simplest, right, remote patient monitoring is having a patient take their own information, putting it into MyChart and uploading it into Epic so that a provider can see it, right? And that's the basics, and we can implement that, you know, yesterday. To the more advanced, I think, which is what Eric is asking. And again, we've, for an example, we have a pilot going with Vivify where they send the patient home with the tablet, that they can do the video visits on, and they automatically upload wirelessly, you know, their information to it. And that's with our heart failure and our visiting nurse right now. So again, there's from one extreme to the other. And I think what we're trying to do right now is take a step back on where are the majority of the needs that our clinicians do, where do they fit in the more simpler one, or the really more complicated one, which again, to, as many of us know, more costly, who pays for that, who's going to reimburse us for that. So we're trying to answer all of those questions and decide where does it fit and where do we move forward so that we can get you know, the largest volumes and be effective for the most patients as we expand our remote patient monitoring.
Mm-hmm. And how do you think that you're going to ultimately watch the data? Or is there a clinical, you know, sort of a dedicated care team within Yale that's going to watch the data? Or are you looking to have a provider outside of Yale do that? How's that going to work?
Again, all questions on the table, right? Because if you've worked with any vendor, you know that they offer that, but you're paying for a service, right? So is it more costly to have it in-house, or is it more cost effective to have a vendor do that for you? I think these are all questions that any of us who are looking into remote patient monitoring are now trying to answer.
Right, right.
And Chaz, we have another, like a few questions on our question and answer board. Allison is asking, if a nurse or provider wants to share patient education materials while on the telehealth visit, can they do it with the RxHealth platform, or does it need to be via the Epic patient portal?
So two things, with our new upgrade, one of the reasons why we just did our most recent upgrade in our IT platform was the ability for our providers to be able to share screen within the platform. So if many of you are used to using Zoom, our platform is very similar, where they could pull up an X-ray, share the screen and review that X-ray directly with the patient over the video visit. That was something we couldn't do before. So that's been a positive, and it's something that Chaz and the IT team worked very hard to do, as well as, again, just while I'm talking about it, a few of the other large things were our ability to incorporate interpreter services into our video visits, something that was very important and allowed us to be compliant. And so that is something else our new functionality access to do. I think the other half of that question was being able to share educational documents, and that can be done through our patient portal through MyChart. You can easily attach a PDF and send it off to someone after their visit. And so again, those are workflows we do have in place today.
But then one other point is, again, if people have issues logging into MyChart, we don't have it built currently, but you could very easily, like what we're doing with GI, send educational information to the patient via RxHealth.
Right.
Thank you.
We primarily like to do it through MyChart, though, just full transparency.
Mm-hmm.
We have another question from an anonymous attendee. They're asking, what about physician buy-in? How did you encourage them to participate when they already have busy schedules?
Well, I honestly, if you're talking about the buy-in to do video visits, they really didn't have a choice when COVID hit, right? Because it was see them over video, or you're not seeing your patients currently. I mean, all of our clinics were literally closed here in the Northeast. And so that, I think, is what I always say. I've been on the telehealth for 3 years. I would still have been out there for 10 years trying to raise my hand saying, who would like to try video visits with us? But COVID changed all of that, because all of a sudden every single provider got exposed to it. And then they just learned how to do it, and now they're willing to keep it incorporated into their schedules. As far as the busyness of their schedule, I think, again, what I had said to earlier, I think what we're hearing now is providers enjoy doing it. They see the benefit of doing it. They see the patient experience benefit from it. But now fitting it in, like you're saying, fitting it into their busy schedule, which is why we're encouraging our providers to make dedicated telehealth sessions so that the ease and the flow works better. And they can do those remotely as well. You do not need to be in a clinic to do a telehealth provider session. You can be at home, you can be in your faculty office, you can be wherever to do your session. And again, I think that is a benefit to the providers as well. So again, and plus on the other side, you're decreasing your clinical costs because you don't need the space to be doing a full telehealth clinic. You can open up that space and have someone else there seeing face-to-face. So that's another value add when it comes to telehealth.
And I can tell you a handful of our providers, and I think probably even more than that now, are dedicating days to basically work from home and do telehealth visits. And some of them they said they can see more patients using telehealth than they could previously because they had to run from the clinic to a different area.
Exactly.
Dedicating days just to telehealth. And they have their staff engaged on those days to make sure that the patients are prepped and ready to go, and that if the patient has any issues, they reschedule them right then and there. And it's a well-oiled machine for some of these providers, and we're just, again, getting that education to our other providers to help them in the same manner.
Yes,
Yeah.
and anyone who works for a large system like ours, even decreasing windshield time for our physicians, instead of having, maybe you are located and you practice in 3 different sites across a small state like Connecticut, is still some driving time. And again, sitting in traffic and all of that goes away when maybe you don't have to do that and switch from start one place in the morning and go to another clinic in the afternoon. Now maybe you can start in one place and do a telehealth clinic in the afternoon and only go to certain places. So again, there's a lot of positives as long as, again, you get that operational workflow and you're working with your leadership to put it all in place.
Mhm.
We have another question from Tim, specifically for you, Chaz. What do you think about the potential derived from the Amwell Taito Care partnership?
So we've actually looked at Taito Care. I think that I'm interested to see how that plays out, just because a lot of other vendors also integrate with Taito Care. I think that Amwell is probably trying to look at it from a peripheral perspective, because that's what Taito really brings to it. It allows, an otoscope, stethoscope, all the different peripherals. So I'm not really sure what the play is there yet. I think it's still relatively new, but I do think that there's opportunity there. But again, that Taito does integrate with a lot of other vendors as well. So I'd be interested to see if they take that off the table for other vendors.
I think there was another one that I'll jump in, asking from Tim as well, asking about machine learning and AI, and taking all of this data that's being collected from remote patient monitoring, combining it with the electronic health record data, and applying that to reduce readmission, side effects, outpatient surgery, complications, that kind of thing. Are you thinking or doing anything about that today?
So with one of our remote patient monitoring programs that we just got going back in February, actually, we are using a platform that does allow us to use an AI to kind of sift through some of the data and present what's more relevant to the nurse and to the physician. I will say that they've gone from reviewing thousands of transmissions to remove basically a quarter of what they do is now just RPM. Like, they can get through their day so much quicker now with some of the platforms that we put into place. But again, a lot of these new vendors that are out there, they're all going to implement the same technology. It's just a matter of finding out which one works with our formulary and which one works for the physician as a whole, because one device that might work for one provider might not work for another provider.
Right.
That's what we're running into right now, is that, we have providers that are doing research projects with, pharma companies, and they need to use one specific platform versus others that they just need a cheap blood pressure cuff that can remotely transmit the patient's data. And, we need to find one that's covered by their insurance because they can't afford it.
Mm-hmm. Mm-hmm.
Yes.
Yeah, that's good. And certainly that's the future, and that will streamline a lot of this, a lot of this data pattern recognition, if you will, that AI will provide. I had one other question, if I could, because I forgot to ask it earlier. The Northeast has a lot of states in a very small geographic area, and one of the barriers to telehealth adoption for years has been the whole concept of cross-state licensure of clinicians. What have you seen in that area lately?
Yeah, so Connecticut is not a state that is part of the interstate compact, which maybe others are part of. So again, that also limits us. And so what we saw here, and I'm sure as many of you know who are doing telehealth out there, is that during COVID, every state has put out their public health emergency declarations, which has allowed providers to do telehealth into other states as long as you are licensed within your own state. And so here that was in place for our surrounding states, New York, Massachusetts, Rhode Island, for a period of time, which allowed us to expand our reach to our patients who were either living in those other states, because again, we're very small around here, or who were caught because of COVID in another state, or whatever the circumstance was. And some of those are still in place today. Again, every state continues to have a PHE in place or not. Again, our neighboring state, for example, Rhode Island, no longer has a public health emergency. And so for us to do telehealth into Rhode Island now, our physicians would need to be fully licensed in the state of Rhode Island to go over that state line. And so what we've learned and what we are doing now to move forward is we are actually working within our network development and strategy group to figure out what providers actually see a larger percentage of patients out of state, identifying those providers, and then again, seeing if it is feasible to license them in the states where some of their patients, or maybe the majority of their patients, actually live. And so again, we're working on that process now so that when all of these regulations relax and the PHEs go away, we are continue and we'll be able to move forward with having licensure in those other states. So again, I think it's very important for other entities to think about this. If you're part of the Interstate Compact, it's not as hard because you're already granted licensure into other states. But if you're not, it's something that you may want to think about doing before all of these regulations that are a little lax right now or have the ability to do them in other states go away.
Right, right. That's really good information. Yeah, thank you. Thank you very much for that. I know we've just got a few minutes left, and I want to save a bit of time for closing remarks. Are there any other questions that we haven't gotten to, Charu?
I think there was just one question that I think was answered. It was, what was your educational plan? So I think that was the only one, but we got all the other questions answered.
Okay, excellent, excellent. Well, then in closing, maybe Nikki and Chaz, maybe Nikki, you can go first and give us sort of your closing thoughts around the operational implementation of these sort of automated care pathways with your telehealth program, and then Chaz can talk a little bit about the technical operations and the impact that it's had.
Sure. Yeah, this has been a great discussion. So thank you, everyone. I mean, I think that my closing remarks are just around ensuring, I think we've said this already, but you really have to have a strong operational presence within your telehealth team. Without that, and without those assessments that go on the operational side, it's probably going to be very hard to be successful. So again, implementing things like the RX Health workflow, knowing exactly where it can fit in, where it can be of benefit, and exploring where you can use that are very important. And they sit on the operational side because then you need to train people and instruct people how to use them. So I mean, I think that, as telehealth leaders, we need to ensure that, everyone thinks of telehealth, I think, as the IT side of things because, it's the visual, it's the audio, it's all of that. But I really implore people to think about having first of all, your strategic vision around telehealth with your leadership, and then underneath that, your operational structure to implement, and then working hand in hand with your IT to put it all in place.
Yeah,
Excellent.
I'd agree with everything Nikki said. One of the other things I would recommend is making sure that you have a very well-rounded team. Telehealth is not just the application itself. It is the devices that it is done on. It is the network it is performed on. It is not just the application. There is so much more that goes into it, and there's so many other areas that touch it that it is almost impossible without that well-rounded team to determine when there is an issue, where the issue truly sits. Mm-hmm. There are over 1,000 different iterations of Android devices out there, all different platforms. iOS is a little bit more constricted, so Apple only allows certain devices, and they only allow certain iOSs to be compatible with those devices. And then when you get into desktops, both provider and patient side, it just turns into this giant pile that you have to try to sort through. And you need that technical team in place, and you need that operational team that can help you really get through what the issues truly are, so you can kind of get through the weeds, because otherwise it is very difficult.
Mm-hmm. Mm-hmm. Great comments, Chaz. Thanks. And I can say, as sort of the person on the outside looking in, it sounds like the two of you are a very good team, and I assume that the other members of your team that aren't on this call, it doesn't seem like you're throwing things at each other every day. You're actually working together.
Yes,
So
you have to.
Without working together, it will not work. You truly do have, like, I think Nikki and I probably meet 5 or 6 times a day.
Yes.
Wow. Nice. Really, really good. And the technology and the operations and the workflow, I think those are the high level messages that have really come out of this webinar. And so in closing, I guess I'd like to thank everyone for attending the webinar. I'd like to thank you, Chaz, and you, Nikki, for really sharing some deep experience, because I think a lot of these, we all have sort of webinar, we get, a dozen webinars a day, right? And so it's like, what am I going to attend and what I'm not? And what I find of value is when I can actually take some of the information that I get from a webinar and actually apply it to my daily work. And so thank you for that. And thank you for sharing your experiences. And thank you to everyone else that has contributed to this. Charu, Gaurav, thank you for your contributions to getting the webinar series up and running. And keep an eye out for the upcoming sessions. I hope they're as good as this one.
All right. Thank you.
Everybody.
Thanks. Have a good day.
Bye.
Bye.